Good morning, ladies and gentlemen. The topic of today's lecture is the disorders of veins. And in this lecture, we are going to discuss the varicose veins, deep venous thrombosis or DVT, superficial thrombophlebitis, Mondor's disease, and chronic venous insufficiency. I am Brigadier Retired Asher Ahmed Mashood, and I am Professor of Dermatology and Aesthetics, and you can follow me on my Instagram and email. Venous disorders. Most veins contain semilunar valves, and these valves are lined by endothelium and are found spatially at the junction of the veins with larger branches. The purpose of these semilunar valves is to prevent the reflux of blood and are particularly important in legs where their integrity is important, and the calf muscle pump, the vein, which is called as the venous heart, pumps the blood up to the heart. And these valves counter the gravitational hydrostatic pressure. There are three venous systems: the deep veins, the superficial vein, and the perforating veins or the perforators. The perforating veins or the perforators are numerous but inconstant, and they are meant to connect between the superficial and deep venous system. During the muscular activity, blood is directed from superficial veins to the deep system and up from the foot to the thigh and thence to the abdomen before the venous blood returns to the heart. So the muscle action and muscle pump is important for transfer of this blood from superficial veins to deep veins and then ultimately to the heart. Bicuspid valves are found in all the three systems. Valves may become damaged, thickened, or degenerate with age. Thrombosis also cause valvular destruction, and a recanalized post-thrombotic vein is usually valveless, anatomically distorted, and functionally inefficient. So once a vein recovers from thrombosis, it is functionally inefficient. And this incompetence of valves in these veins are thought to be a most important cause of venous ulceration in the leg. The venous macrocirculation. The venous system of the leg contains a volume of 300 to 350 ml in a healthy standing subject. This is quite an amount. The venous wall contracts in response to the filling, and its function is called as the venous tone. Superficial veins drain through the communicating or perforating veins to the deep system. We already mentioned this. The deep veins are compressed by muscle contraction, shifting the blood column towards the heart against the pressure of gravity. The venous valve prevents the backflow during muscle relaxation, just like it is in the heart. And this mechanism is called as the calf muscle pump. Now, after discussing the usual physiology and anatomy of the venous system, let's start discussing the diseases which are related to the damage in the venous system. The first and the foremost is the deep vein thrombosis, popularly known as the DVT. DVT is a blood clot that forms within the deep veins, usually of the leg, but can occur in veins of arm and mesenteric and cerebral veins. It is the part of venous thromboembolism disorders which represents the third most common cause of death from cardiovascular disease after heart attack and stroke. So after heart attack and stroke, the DVT is the third most common cause of death from the cardiovascular disease. Even in patients who do not get pulmonary embolism, which is the main cause of death due to DVT, recurrent thrombosis and post-thrombotic syndrome are the major cause of morbidity. Incidence and prevalence. DVT and pulmonary emboli are common and often silent, and thus go undiagnosed or are only picked up at autopsy. Therefore, their incidence and prevalence is often underestimated. DVT is rare in children, and the risk increases with age, and mostly it occurs after 40. There is no sexual bias in the incidence of DVT. Risk factors for deep vein thrombosis. The first is reduced blood flow. Reduced blood flow in the veins is created by immobility like bed rest, prolonged general anesthesia, operation, following stroke, or following a long flight. It may also occur because of increased venous pressure. Increased venous pressure develops because of mechanical compression or functional impairment leading to reduced flow in the veins, like neoplasms, like pregnancy, stenosis, congenital anomaly, which increases the outflow resistance from the vein. DVT also results from mechanical injury to the veins, like in trauma to the veins, surgery, peripherally inserted venous catheters, a previous DVT, or intravenous drug abuse. Then increased blood viscosity, such as in polycythemia, in thrombocytosis, and in dehydration, may also lead to DVT. There is increased risk of coagulation as well, like in deficiencies of protein C, protein S, antithrombin 3, factor 5, and leadin. So the increased risk of coagulation also lead to DVT. There are acquired causes of increased risk of coagulation like cancer, like sepsis, myocardial infarction, heart failure, vasculitis, SLE, lupus anticoagulant, inflammatory bowel disease, nephrotic syndrome, burn, oral estrogen intake, smoking, hypertension, and diabetes. So there is a long list of medical illnesses that leads to increased risk of coagulation and DVT. There are constitutional factors as well, like obesity, pregnancy, and increased age. Pathology. In 1856, Virchow postulated that main cause of thrombus formation were the damage to the vessel wall, alteration in blood flow, and hypercoagulability. This is called as the Virchow's triad. So the Virchow triad is damage to vessel wall, some alteration in blood flow, and hypercoagulable state. So if any of the three things occur, then it may lead to thrombus formation. The triggers of venous thrombosis are frequently multifactorial, as we have already discussed, but all resulting in early thrombus interaction with the endothelium. This then stimulates the local cytokine production and causes leukocyte addition to endothelium, which promotes the venous thrombosis. DVT is commonest in lower limb, below the knee, and starts at the low flow sites, such as the soleal sinus, behind the venous valve pockets. Depending upon the relative balance between coagulation and thrombolytic pathway, thrombus propagation may occur. So whenever the balance shifts towards thrombus formation rather than thrombolytic actions, then the chances of DVT increases. So you can see here that there is a decrease in blood flow, as a result of which the blood thrombus formation develop, and this thrombus later on move to the circulation, resulting in emboli. Clinical features of deep vein thrombosis. History. The first and foremost is the pain, which occur in 50% of the patients. There is redness, swelling, which occurs in 70% of the patient. And it occurs usually in the lower limb, but can occur in the arm. So the most common site of DVT is the lower limb. Pain is the most common swelling and redness are the most common symptoms, followed by pain. On examination, there is limb edema, which may be unilateral or sometimes bilateral. If bilateral, if thrombus is extending to the pelvic veins, the limb may be red hot with obviously dilated veins. There will be tenderness and pain on dorsiflexion of the foot, which is called as the Homan's sign. This is an important sign which you have to demonstrate during the examination. That is, on dorsiflexion, the patient feels pain. Pulmonary embolism. The clinical variants of DVT in upper limb DVT, 80% of the patient will have swelling and 30% will have pain and very less chances of erythema. So the main complication of DVT is pulmonary embolism. The paradoxical emboli if an anteroseptal defect is present. Post-thrombotic syndrome also lead to pulmonary emboli. So this thrombus is dislodged and enter the vein and enter the heart, and from the heart it enters to the lungs and resulting in pulmonary emboli. The differential diagnosis of DVT are cellulitis, post-thrombotic syndrome, especially the venous eczema and lipodermatosclerosis, trauma, superficial thrombophlebitis, peripheral edema due to heart failure, cirrhosis, and nephrotic syndrome, venous or lymphatic obstruction, atriovenous fistula and congenital vascular abnormalities, and vasculitis. So both infective and non-infective causes may result in little confusion in the diagnosis. Classification of severity. The provoked, due to acquired states like surgery, oral contraceptives, trauma, immobility, obesity, and cancer. Unprovoked, due to idiopathic or endogenous reasons, most likely suffer recurrence if anticoagulant is discontinued. Then proximal, above the knee affecting the femoral or iliofemoral vein, much more likely to lead to complication like pulmonary emboli. So if the above knee DVT, then more chances of pulmonary emboli, and distal below the knee. So you can classify the DVT as provoked or unprovoked, and proximal and distal. Disease course and prognosis. Many DVT will resolve with no complication. Post-thrombotic syndrome occur in 43%. 2-year post-DVT, 30% mild and 10% moderate and 3% severe post-thrombotic syndrome. Risk of recurrence of DVT is higher, up to 25%, because most of the reasons that results in DVT, they will come back again. Death occur in approximately 6% of patients with DVT, and 12% of pulmonary emboli cases within 1 month of, and 12% of pulmonary embolism cases within 1 month of the diagnosis. So 12% of the DVT patient will end up in pulmonary embolism, and only 6% of them will die. Early mortality after venous thromboembolism is strongly associated with pulmonary embolism with advanced age, if patients are suffering from cancer and some underlying cardiovascular disease. Investigation. We usually order D dimers. It is quite sensitive to DVT but not specific. Then compression duplex ultrasound. This has a sensitivity of 97% for proximal and 73% for distal vein thrombosis compared with phlebography. It is non-invasive, simple, easy to repeat, and inexpensive and free of complication. Then radiology, MRI, and CT venogram may be useful adjuvant but are expensive and are not always available. So compression duplex ultrasound is the best tool. General investigations include chest X-ray, routine blood tests like full blood count, liver function test, urea and electrolytes, and urine analysis. If DVT is unprovoked in patient over 40, then mammogram and abdominal pelvic CT to look for any cancer, antiphospholipid antibodies to rule out antiphospholipid syndrome, and test for hereditary thrombophilia. There is a score for DVT which is called as the Wells score. You may be asked about this score during the examination. So Wells score give 1 mark each to an active cancer, paralysis, paresis, or plaster immobilization, bedridden patient for 3 days or more, with or without surgery, or after surgery within 12 weeks. Then local tenderness along the distribution of deep venous system, again 1 mark. Then swelling in the leg, again 1 mark. Calf swelling at least 3 centimeters larger than asymptomatic side. Pitting edema confined to symptomatic leg, collateral veins, and previously documented DVT. DVT is likely if the score is 2 or more. So there are a lot of things, and in the Wells score, and in DVT you can find any of these 2 things. Then you will be able to label it as DVT with confidence. As far as the treatment is concerned, for proximal deep vein thrombosis, the anticoagulants are the first and the foremost. Low molecular weight heparin for 5 days or until INR is more than 2 for 24 hours. Unfractionated heparin is given for patient with renal failure and increased risk of bleeding. Then vitamin K analogs for 3 months. In patient with cancer, consider anticoagulant for 6 months with low molecular weight heparin. In patient with unprovoked DVT, consider vitamin K analogs beyond 3 months. Rivaroxaban is an oral factor 10A inhibitor and has recently been approved by FDA and NICE and is attractive because there is no need to monitor INR while giving rivaroxaban. Thrombolysis. If there is symptomatic iliofemoral DVT, symptoms of less than 14 days duration, there is otherwise a good functional status, there is life expectancy of 1 year or more, and low risk of bleeding. So in such case, the manual thrombolysis is performed. Compression hoses should be worn below knee, graduated compression stocking, which maintain an ankle pressure greater than 23 millimeter of mercury for 2 years if there is no other contraindication, especially the patient who are prone to DVT. Inferior vena cava filters. If anticoagulants are contraindicated and if emboli are occurring despite of adequate anticoagulation. Now we will discuss the second topic, and this topic is superficial venous thrombosis. We have already discussed the DVT. Now we are coming to the thrombosis in the superficial venous system, which is also known as the superficial thrombophlebitis. This is a common condition where there is formation of thrombus in veins near the surface of the skin, which is usually associated with inflammation of the walls of the vein. It's an uncomfortable but self-limiting condition, often seen in the lower leg associated with varicose veins and in hospitals at the site of intravenous cannulas. However, it can be associated with deep venous thrombosis and venous thromboembolism. Incidence and prevalence. The superficial venous thrombosis is a common condition. 25 to 35% of all hospitalized patients are thought to experience the superficial phlebitis at the site of venous cannulas. Mean age of onset is 60 and commoner in female. There is no racial predilection. Migratory thrombophlebitis may be associated with underlying carcinoma such as pancreatic cancer or Behçet's disease. Pathophysiology. Pathogenesis of superficial venous thrombosis is almost similar to DVT, although trauma to the vein is thought to be the primary trigger. So in the Visho triad, you remember that there is a trauma, there is an element of stasis, and there is an element of increased coagulability. So among these three factors, the trauma is one of the most important factors in superficial venous thrombosis. It usually develops in lower limb. In 60 to 70% of the cases, the greater venous vein system, and in 10 to 20% cases, superficial saphenous vein system is involved. The main cause of superficial venous thrombosis in lower leg is varicose vein. Superficial venous thrombosis in main trunk of saphenous vein has a strong association with venous thromboembolism. The main cause of superficial venous thrombosis in upper limb is iatrogenic, especially after an intravenous catheter or infusion of drugs such as chemotherapy or heroin. Mondor's disease is another form of superficial venous thrombosis. We are going to discuss it in detail. Clinical features of superficial venous thrombosis. There is gradual onset of localized tenderness, redness along the path of superficial vein, history of intravenous catheter at the site, and there may be multiple varicose veins. On examination, the overlying skin is red and hot. Swelling and tender firm cord is palpable along the location of the vein. If it occurred within varicose vein, then there may be bleeding. So, unlike DVT, there is less swelling, less edema, and pain in DVT, pain in superficial venous thrombosis is much more than pain in DVT. And inflammation is much more, that is tenderness and redness. Clinical variants are migratory thrombophlebitis, you can see in this picture, and thrombophlebitis of superficial vein of breast and anterior chest, which is the Mondor's disease. Complication and comorbidity. This superficial thrombophlebitis may extend into the deep venous system and lead to DVT and pulmonary embolism. If thrombosed veins do not get recanalized, patient can develop post-thrombotic syndrome. There will be post-inflammatory hyperpigmentation over the affected vein. There is persistent firm subcutaneous nodules at the site. Secondary infection possibly lead to septic emboli, abscesses, and septicemia. Investigations. Duplex and compression ultrasound is the major investigation to detect the location and extent of superficial venous thrombosis and exclude DVT. Consider the test for underlying malignancy if there is migratory thrombophlebitis. Blood tumor markers should be done, chest X-ray and CT abdomen and panels, and mammogram in female. Coagulation profile is must to exclude the hypercoagulable state like factor V Leiden, protein C and S deficiency, antithrombin 3 deficiency, and antiphospholipid antibodies. Treatment of superficial venous thrombosis, the medication. Like DVT, low molecular weight heparin is given for 3 months. Best at reducing the local signs and symptoms and reducing the risk of extension to deep system if we start it early. NSAIDs, similar in efficacy to low molecular weight heparin but easier to administer. The ideal way is to start with low molecular weight heparin, then shift to NSAIDs. Antibiotics is only helpful if there is suppurative thrombophlebitis. Surgery. Excision and ligation. When thrombus is found in or near the saphenofemoral junction or saphenopopliteal junction, and patient is already started on no molecular weight heparin, in such case, the superficial vein should be excised and ligated. Sclerotherapy and stripping should only be performed some months after the acute superficial thrombus has settled. Puncture and evacuation of the thrombus can be squeezed out through a needle puncture. Then compression, hosiery, and bandage is used as an adjuvant to medical and surgical treatments. The third condition we are going to discuss is thrombophlebitis migrans. This is different from the superficial vein thrombosis, as this form of superficial vein thrombosis is recurrent and diffuse, affecting the large and small veins throughout the body. Pathophysiology is not fully understood. In the thrombophlebitis migrans, there is always an association, or most of the time, an association with malignancy. So it is suggested that there is a state of chronic disseminated intravascular coagulation. Not acute, but chronic. So history, patient develop crops of painful red lumps and streaks in the skin. It may resolve and new one develop. Lesion appear on leg, arm, abdomen, and flanks. Presentation. The lesions are hot, tender, linear, or oval subcutaneous lumps or streaks. The overlying skin is usually intact. Differentials are cellulitis, paniculitis, DVT, and states with increased coagulability. Investigations. Ultrasound to confirm the diagnosis. Clotting studies and tests look for underlying malignancy. Then CT scan, ultrasound, MRI, and even positron emission tomography or PET scan of abdomen may be necessary to pick up any underlying cancer, especially pancreatic cancer. Management. Treatment is usually conservative and patients should be treated with adequate anticoagulation. Lowering the triglycerides is advisable and exercise is a good prophylaxis. Medical elastic compression stockings and bandages may alleviate the symptoms. In Behçet's disease, immunosuppressive medications are given. Then we are going to discuss the fourth condition, which is the Mondor's disease. This is again a form of superficial venous thrombosis in the chest wall and the affected vein that include the lateral thoracic vein, the superficial epigastric vein, and thoracoepigastric vein. Similar cases are reported in antecubital fossa, inguinal region, axilla, penis, abdomen, and lower limb. This is a rare disease, less than 500 cases are published. Typically, patients are between 30 to 60 years, and male and female male ratio is 3:1. And there is no racial bias. Etiology. It is a superficial venous thrombosis. 1/3 of cases are idiopathic. Most of the rest are related to trauma, that is injury, muscle strain, poorly fitting bras, surgery, breast prosthesis, etc. Rare causes are underlying breast cancer, hypercoagulable states, and connective tissue disorders. In the penile type, surgical trauma, excessive sexual activity, sexual vacuum practices, use of constructive elements during sexual activity, intravenous drug abuse, prolonged sexual abstinence, local or distant infection, venous obstruction due to bladder distension, and pelvic tumor have all been implicated. Clinical features. The lesions may involve the subcutaneous vein on the upper anterolateral chest wall, producing fibrous painful cords with skin retraction. However, unlike the classical superficial venous thrombosis, there is no overlying cutaneous inflammation. So the absence of cutaneous inflammation differentiates Mondor's disease from superficial thrombophlebitis. The Mondor's disease of the penis. It is a painful cord with local preputial inflammation. Mondor's disease after breast surgery. In association with axillary lymph node dissection, it is in breast cancer, it is characterized by palpable cords with a bowstring across the axilla. These are palpable cords. creating a web of the skin. This is called as the axillary web syndrome. The cords are painful and restrict the shoulder movement. There is usually no concomitant superficial venous thrombosis. The differential diagnosis include cellulitis, erythema nodosum, skin metastatic carcinomas, lymphangiectasis, and lymphangioma. Disease course and prognosis. It depends upon the site and type of the disease. The Mondor disease on the chest wall is generally benign, self-limiting, with spontaneous resolution over 2 to 8 weeks. Investigations. Diagnosis is largely clinical. Ultrasound examination can diagnose superficial thrombus and exclude a deep thrombus. Mammography can be helpful if there is a suspicion of underlying carcinoma. Management. The Mondor's disease of the chest wall is benign and self-limiting, and usually there is no requirement of anticoagulation and simple analgesics are required. The Mondor's disease involving the other venous territories, anticoagulation is recommended, and in penile disease, the superficial dorsal vein of the penis is treated with thrombectomy or excision. Axillary web syndrome, the facial fibrous bands are manually ruptured. Now, one of the most common conditions which we come across in our clinical practice is the varicose vein. Varicose veins are visible, dilated, tortuous elongations of larger, superficial venous trunks and their tributaries. The reported prevalence is high, varying from 10 to 50% of the adult population. This prevalence increases with age and is more common in female. There are associated diseases to varicose vein, including Klippel-Trenaunay syndrome, and where there is congenital malformation leading to varicose vein. Pathophysiology. It is mainly the incompetence of the valves that disrupts the normal flow of blood and cause venous hypertension, resulting in varicosities in the vein. The varicose veins are divided into primary and secondary. A genetic bases have been thought to be possibly relevant, and incidence is twice high in urban population than in the rural population, definitely because of less movement. The severity of symptom does not necessarily correlate with the size and extent of the visible varices, and that in turn does not always correlate the degree of reflux or severity of venous hypertension. The clinical features. Symptoms. It's often asymptomatic but unsighted. Sometimes there is aching, which is worse on standing. There is ankle swelling. Other signs are signs of palpable and dilated and tortuous veins. Then there will be reticulate veins and telangiectatic veins or spider veins. So you must note the signs of chronic venous insufficiency, and these signs include pigmentation, swelling, eczema, lipodermatosclerosis, and ulceration. We are going to discuss these signs individually as well. The classification of severity of varicose veins. This is called as the SEEP classification. In SEEP classification, C is for the clinical scores, that is C0 to C6, with no signs to very severe venous ulceration. Then etiological classification. EC is congenital, EP is primary, ECS is secondary, EN is no venous cause. Then A is for anatomical, that is if superficial veins are involved, perforators are involved, D veins are involved, and no venous location identified. And P is for pathophysiological. That is, if there is a reflux, there is an obstruction, there is no venous pathophysiology. Disease course and prognosis. 3 to 6% of patients with varicose vein will get venous ulcers in their lifetime. There is a suggestion that obesity, increased age, and genetic factors contribute to the causation of varicose veins as well as to the venous leg ulcers. Investigation of choice is the color duplex Doppler ultrasound. It is the investigation of choice for detecting deep vein reflux. Management. Patient advice and information discuss the cause and natural history of varicose vein, give advice about the weight control, and light to moderate physical activity. Then it is important that the patient should be referred to a vascular unit if there is any of the following, that is, bleeding from the varicose veins, primary or symptomatic recurrent varicose veins. There are lower limb skin changes like pigmentation, eczema, which shows a chronic venous insufficiency, or signs of superficial vein thrombosis characterized by hard, painful veins, and suspect venous incompetence, an active or healed venous ulcer. The different treatment modalities include the endovenous laser treatment, which is the new modality. And this is done by a laser fiber inserted into the varicose vein, and the laser beam is turned off, and this beam slowly will open the closed veins, and laser fiber is then slowly removed. Then ultrasound guided foam sclerotherapy. The sclerosant include the following: the detergents, which disrupt the vein cellular membrane, which is protein theft denaturation, sodium tetradecyl sulfate, pylodoconol, sodium moruate, then ethanolamine oleate, osmotic agents. The osmotic agents damage the cell wall by shifting the water balance. The osmotic agents include hypertonic sodium chloride, hypertonic saline solution, then sodium chloride solution with dextrose, which is called as the sclerodex. Chemical irritants may be used like chromogate glycine and pyrodenated iodine. So the ultrasound guided sclerosant foam is injected, which ultimately occludes the vein. Then finally, surgery. Surgery to remove these dilated vein. The compression bandage should not be used for more than 7 days after interventional treatment. The non-interventional treatments include: do not offer compression hosiery to treat varicose vein unless interventional treatment is unsuitable. So if interventional treatment is suitable, then it is better to go for interventional treatment. Do not carry out the interventional treatment for varicose vein during pregnancy other than in exceptional circumstances, because pregnancy exacerbates varicose veins, and following pregnancy, the varicose vein improve. So it is better to use non-interventional treatment during pregnancy. The next and the most important subtopic of today's lecture is the chronic venous insufficiency. This is the state which occurs when blood no longer flows in the correct path from superficial system into deep system and thence back to the heart. So this results in venous congestion and impairment of the venous system. The chronic venous insufficiency is classified anatomically into 3 categories: the superficial vein insufficiency, perforating vein insufficiency, and deep vein insufficiency. Reflux is the most common type of abnormality, but in about 10% of the cases, a functional obstruction from thrombosis will be present. If untreated, the venous insufficiency in either the deep or superficial systems causes progressive syndrome of chronic venous insufficiency. The chronic venous insufficiency is common and is disabling. Those with superficial venous insufficiency usually present with varicose veins initially. Then chronic venous insufficiency is most frequently post-thrombotic and occur in less than half of the patients after DVT. In large studies found a prevalence of 7% of varicose veins and 0.86% of symptomatic chronic venous insufficiency. Serious chronic venous insufficiency leads to venous ulcer, which is estimated prevalence of 0.3%. So if the chronic venous insufficiency is mostly related to the varicose veins, and the chronic venous insufficiency is most frequently due to DV, deep venous thrombosis. The chronic venous insufficiency prevalence increase with age. The causes of venous insufficiency. They include the venous disease, impaired muscle pump, and congestive cardiac failure. Venous diseases, which we have already discussed, the superficial venous incompetence, that is the varicose vein, deep venous incompetence, primary deep venous obstruction, rare, previous DVT, and external compression. And the impaired calf pump include the immobility, joint disease, paralysis, obesity, and congestive cardiac failure. Pathophysiology of venous reflux and venous hypertension. It is thought that there are two elements to the pathophysiology. The first is the abnormal venous blood flow with reflux. And the second, a chronic inflammatory process that leads to the skin changes which are seen in chronic venous insufficiency. So in venous insufficiency, the pathophysiology is divided into two main causes. The first is the abnormal blood flow and reflux of the blood back to the superficial veins. And number two is the chronic inflammatory changes which result in the changes which we see on the skin. Reflux is the presence of retrograde flow in the vein in response to the stimulus like calf cues. It occurs during standing when valves are incompetent. It can occur in superficial, deep, and perforating veins of the lower extremity. An elevated and sustained ambulatory venous pressure, which is the venous hypertension, is indicative of chronic venous insufficiency. It is mainly because of the reflux. Such heightened pressure is transmitted distally as far as the capillary system of the skin, causing capillary hypertension and eventually leading to the destruction of the nutritive capillaries. So this back pressure due to the reflux causes the increase in blood pressure in the veins, which is transmitted to the capillaries and ultimately leading to the destruction of the capillaries supplying blood to the skin. Pathogenesis of the chronic inflammatory changes due to venous insufficiency. So as a result of all this, the backflow, the reflux, and the venous hypertension, the leukocytes accumulate in the leg when their chronic venous pressure is high. The activated leukocytes migrate out of the vasculature and release transforming growth factors, which stimulate the collagen production, resulting in dermal fibrosis. This dermal fibrosis is ultimately the cause of dermatosclerosis or lipodermatosclerosis. The vascular cells and inflammatory cells and macrophages produce proteolytic enzymes that break down the extracellular matrix, resulting in reduced healing and promote ulceration. The increased capillary permeability due to the venous hypertension and extravasation of RBCs lead to elevated level of ferritin and ferric iron, resulting in skin pigmentation. So this is the cause of pigmentation, that is increased permeability of red blood cells to the skin. Other factors that play a role in pathogenesis are the genetic factors. There is a genetic basis thought to be relevant in pathogenesis of varicose vein and also the chronic venous insufficiency, and this may be a feature of Clipperton-Oni syndrome. Environmental factors include the sedentary lifestyle, which reduce the efficiency of muscle pump and leads to reduced venous return and increased venous pressure in the leg that leads to increased venous hypertension, capillary leak, leukocyte migration, cytokine release, and RBC release, pigmentation, and all the other features. So the clinical features of venous insufficiency include the first, pitting edema, especially around the ankle. This is worse at the end of the day and disappear at night. Patient may complain of tight feeling in the leg and night cramp later on. Then there is a term which is known as the corona phlebatica paraplantaris, or in simple words, the ankle flare. It is the presence of abnormally visible cutaneous vessels at the ankle, as you can see in this picture. Pigmentation in the gaiter skin is pinpoint patchy pigmentation, which may extend over the large indurated area. And this pigmentation is mainly because of extravasation of WBCs and the hemosiderin pigmentation. Then pressure erythema is grouped and confluent. Very small telangiectatic vessels develop near the incompetent perforating veins. So these are the telangiectatic vessels, and this is the pressure erythema. Then venous eczema or the stasis dermatitis starts around the varicosities at the medial side of the ankle. It is relatively sharply demarcated. It can be acute and chronic and may lead to secondary spread onto the adjacent and distant non-contact sites. Then a very important complication of chronic venous insufficiency is lipodermatosclerosis. It is pathognomonic of venous and lymphatic hypertension and is associated with increased risk of leg ulcer development. Early stages lipodermatosclerosis, skin may feel indurated and has inflamed erythematous appearance with tenderness and pain. In long-standing disease, there is woody hardness to the skin and subcutaneous tissue with pigmentation. So the skin of the lower leg is woody hard, indurated, tight, and give an inverted champagne bottle appearance. This is actually because of the increase in dermal fibrosis, which results from the leukocyte migration and inflammation. Then another common complication of venous insufficiency is atrophy blanchi. This is atrophic ivory white depressed skin lesions located on the lower leg. They are usually multiple lesions and diameter is around 0.5 to 15 centimeter, associated with ulcers, and ulcers are known as the stellate ulcers, like you make stellate wound with a knife. And these can be very painful. One or more capillaries are often occluded with fibrinoid material. Then the end result of venous insufficiency is the venous ulcer. And this venous ulcer will be discussed in detail in the next talk. And this is a difficult ulcer to treat. The complications and comorbidities are thromboembolic disease, venous ulceration, and secondary lymphedema. Disease course and prognosis. About 4% of patients with varicose vein progress to more severe clinical stages, and 3 to 6% develop venous ulcer in their lifetime. Patient, if develop lipodermatosclerosis, there is increased chance of developing venous ulcers. About 3% of patients with DVT will go on develop chronic venous insufficiency. Investigation. Again, the duplex ultrasound, MRI venography, phlebography or venography, then venous pressure measurement, and venous plethysmography. Treatment. The aim of treatment is to relieve the symptoms of chronic venous insufficiency and possibly correct the underlying cause. Patients should be referred to a vascular unit for assessment. Interventional treatment are usually undertaken by vascular surgeons or interventional radiologists. There can be graduated compression stockings, class 2 or class 3. Then there is a treatment of stasis eczema, atrophy blanchi, lipodermatosclerosis, which will be undertaken by the dermatologist and will be discussed or were discussed in the relevant sections. So this brings to end of this talk. This was a very important and useful talk since the patient of venous ulcers and venous eczemas are very common and we frequently get such cases in the examination. I thank you all for a very patient listening. Good afternoon and have a good day.